Hello everyone, this is Dr. Saroj Siddiqui from the platform of UKMLA with DSS, and let's just move on to the next lecture of the success course of the UKMLA 2 exam. Okay, so in this lecture, what we are going to cover is basically the surgical cases, and we're just going to touch upon the surgical consultation. Okay, so as you can see on the screen, there are different cases that comes from the surgical category. Okay, the first is the pre-operative consultation. Okay, that is something which is the unique part. Okay, and all of the other cases is, you can see that this is uh, the counseling structure, the discharge counseling. Okay, then explanation counseling, in which you may have to explain a particular uh, procedure. Then there are some follow-up stations, uh, like which are there. Okay, and there are a few sessions in which you just have to take the medical history taking approach, like the surgical cases like intermittent claudication, biliary colic, acute pancreatitis, appendicitis. Okay, so like most of the surgical cases, they're not typically and exclusively, surgical cases. They come either as counseling, either as follow up, or they may show up as a medical history taking. Okay, and as far as the approach of the discharge counseling and the explanation counseling is concerned, we're going to do that later on in the upcoming lectures. Okay, same goes for the follow up. We're going to have a class on the follow up structure as well, and how to go about the follow up stations. Okay, the medical history taking approach, we have already covered it in the initial lecture. Okay, what is different in the surgical consultation is this, the pre-operative consultation. Okay, and there are a couple of cases that show up in which you have to perform the pre-op, and there is a way to go about the pre-op session. There is a different way of doing the pre-op history, or doing the pre-op data gathering, and make sure that patient is ready pre-operatively to get into a surgery. All right, and we are going to discuss that particular structure, and then I'm going to discuss a couple of important things regarding the surgical stations that you should be aware of before you start actually studying the surgical station, and before you start practicing the surgical station. Okay, so let's just go through the pre-op assessment in detail. In the case note, you would be seeing that okay, you are an FI2 or a surgical unit, or it can say that you are an FI2 in the anesthesiology unit. Okay, and the patient Liz Smith would be a 30-year-old woman, or whatever the age is, has come to you, and she's diagnosed with an ovarian cyst, or any surgical diagnosis would be given, and it would be mentioned that she's scheduled for a surgical cystectomy, or she is scheduled for an laparotomy, or any surgical procedure name would be mentioned over here, and the task would clearly state that you have to perform a pre-operative assessment. Okay, and the moment you get this thing, you know that you need to follow this particular structure that I'm going to teach you. Okay, so let's just start, and let's just go through the structure one by one. All right, so in the very first layer, okay, what you need to do is that you need to explore the symptoms. Okay, now you're going to say that okay, like there is no symptom that is mentioned over here. It is just a scenario that talks about ovarian cyst and surgical cystectomy, or they may just talk about appendix and appendectomy. What symptom are we talking about? So before coming to this diagnosis, the patient may have some symptom, must have some symptom or the other. All right, so you just have to explore that, and very briefly. Okay, what a lot of people end up doing is that they start taking the history, that okay, can you please tell me what was your symptom? Yeah, doctor, I was having pain in my right lower quadrant. And then they start the entire Socrates and the entire Meftosa and the PDIS and the flaws, and they just completely miss the entire purpose of the pre-operative assessment. Okay, what I mean by exploring the symptom in this case is just the what, when, and how. Okay, like what happened? Yeah, doctor, I had a right lower quadrant pain. Okay, since when were you having it? Yeah, doctor, I was just having it for a couple of weeks now. Okay, and how is it right now, or how did it happen? Just a couple of questions, just 2 to 3 questions. You should not be spending more than 5 to 10 seconds on this particular aspect. Okay, then what is like more important in the first year is what have you been told about it. Okay, what idea do they have? Okay, about a particular condition, about the surgery, about the diagnosis. Okay, Just a open-ended question. What have you been told about your condition? What have you been told about the surgery that is scheduled? Just to try to understand, okay, what understanding the patient have about their condition or about the procedure that they're about to undergo. Okay, and then you're going to ask that, are the symptom well controlled? Are you all right now? Will it be okay if we can, just have a chat? Are you in pain right now, or is it well controlled? Is it well settled? So the first layer is more of a rapport building kind of a thing, okay, in which you just briefly touch upon the symptoms, and you just ask about and you assess the knowledge, that how much idea do they have about their condition. All right, so that is the sole purpose of it. Do not invest more than 45 seconds on this layer. Again, exploring symptoms does not mean at all that you get into a lot of detail and then you start doing the entire Socrates and the entire OT para. Don't end up doing this. You're going to regret it really bad, because you would not have enough time to do the actual pre-op assessment. Okay, the next section that is like really important, which is the head to toe head to toe questions, or the review of the symptoms. Okay, so I've like listed down what 15, 16 different symptoms. It's you just don't rote learn it, that okay, I have to ask about headache, I have to ask about the weakness, I have to ask about vision problem. The very simple and very easy way to go about it is that, like, just imagine that there is a person standing in front of you. Okay, and start from the very top. Okay, the head. In the head there can be multiple problems. There can be headache, okay, it can be neurological problems that may lead to weakness or numbness. Then move a bit below, you're going to see the eyes. So you're going to ask about any vision problem. Okay, uh, there can be some discharge that may come from the eye. You can ask about that. Ear, there can be some ear pain, ear discharge. Okay, so just ask about any discharge, any ear pain, any problem with the vision. Okay, since the head is involved, the central nervous system is involved. Talk about dizziness. You're talking about the ear as well. Okay, talk about vertigo. That any dizziness, any vertigo. Okay, then move a bit below. The mouth is over here. Okay, talk about any a cough that might be coming. The nose is here, so think about the respiratory and the pulmonary system. That okay, any shortness of breath, and then you move a bit below. The chest is there. Okay, the heart is there. You're gonna ask about any chest pain. Okay, then you go further below to the stomach. Stomach can have various problems like any vomiting, any stomach ache, any diarrhea, any constipation. Then you go further down to the urinary the system, and you're gonna ask about that any problem with the urine. Okay, and once you're done with that, go a bit more below. You're going to see the bigger joints like the pelvic joint, the knee joint. Okay, so talk about the joint pain. That do you have any pain in the joint? Do you have any pain in the muscles? Do you have any pain in your legs? Okay, and then you can just ask about the overall well-being. That okay, how are you doing? Any fever or flu-like illness? Okay, so I did not memorize all of these. Okay, I just use the head to toe method. That okay, if I'm at the head, what can be the possible problems? If I'm at the nose, what can be the possible problems? If I'm at the chest, what can be the possible problems? If I'm at the stomach, what can be the possible problems? Okay, so that is the easiest way to do the ROS, or the review of symptoms. Okay, don't rote learn this, because it is going to put you in immense pressure, that okay, I'm forgetting something. But if you just follow this method of ROS, then it's unlikely that you are missing out any system. Okay, each and every system would be covered. You have covered the CNS, you have covered the musculoskeletal system, you have covered the ophthalmic system, you have covered the ENT, you have covered pulmonology, you have covered cardiovascular, you have covered GI. Okay, all the major symptoms have been covered. You assess the joint. You have covered the orthopedics and the rheumatology as well. You have assessed the kidneys. You have assessed the renal part, the nephro, and the urology as well. Okay, so you have covered each and every system just by this trick and just by following the head to toe method. Okay, so don't rote learn all the 15, 16 symptoms. Just make sure you ask about it. And like, this is something that I shared in the very first lecture as well, in the initial lectures as well, that do not phrase your sentence in a very very long way, that by any chance are you having any headache, by any chance are you having any weakness or numbness. By any chance, Mr. Adam, are you having any problem with the vision? By any chance, are you having any discharge from somewhere? That is going to take a lot of time. Like you're going to lose your 4 or 5 minutes of data gathering in just doing the review of system if you phrase your sentences like this. Just say any headache, any weakness, any numbness, any vision problem, any discharge, any dizziness, any vertigo, any cough, any difficulty in breathing, any chest pain, any vomiting, any stomach ache, any diarrhea, any constipation, any problem with the urine, any joint pain, or any fever or flu like illness. Very rapidly, just use any and the symptom, any and the symptom, any and the symptom. Okay, that is the easiest way to go about it. It should take you like a minute and a half to just make sure that you're done with this. All right, so pretty much simple and pretty much straightforward. Now comes the most important and the most significant part of the data gathering when it comes to the pre-op assessment. Okay, now what they actually want to test in your pre-op is that, do you know the anesthesia specific history? Okay, are you aware of the questions that an anesthetist team or an anesthesiologist is going to ask? Okay, or the parameters that an anesthesiologist is going to note when he sees the pre-op assessment. Okay, and these questions are like really important for every pre-op case, okay. And what does it contain? Number one, you got to explore the past surgeries. Okay, did you have any surgery in the past? Okay, if yes, then did you have any GA related complication, which means that general anesthesia related complication? So don't end up using these abbreviations. GA related complication, they wouldn't know what GA is. Okay, so you got to verbalize it properly, that did you develop any anesthesia related complications? Okay, by any chance, did you get admitted to the ICU after your operation or after your surgery? By any chance you developed any nausea or vomiting after the surgery? Okay, all of these things are anesthesia related question that shows that, okay, the patient may have had some complications in anesthesia. So this time, once we administer the anesthesia, we gotta make sure that we are delivering it very safely, and we are monitoring the patient very closely for any complication, because the patient may be at a risk of getting admitted to the ICU after the operation. All right, so it's a like important parameters. Then there are a few assessment that you need to make sure that you do. Sorry about that. Yeah, so that includes the mouth opening, that can you open your mouth properly? Are you having any difficulty in opening and closing your mouth? Can you please show me how you can chew? Okay, can you please open your full mouth for me? Okay, all of these things needs to be asked. Why mouth opening is important? Because when the patient is undergoing general anesthesia, the patient may have to be intubated, and the mouth opening can really affect the ease of intubating a patient. Okay, so mouth opening is like very important. Then you have to ask about that, by any chance do you have any neck stiffness, okay, or any pain in the neck? Why? Because again, intubation requires a posture like this. Okay, and any stiffness in the neck would make the intubation difficult. And then you need to ask about that, by any chance do you have any artificial dentures? Why you gotta ask that? Because again, intubation, think about intubation. Whenever you are intubating a patient, okay, the laryngoscope gets hit on the teeth, and it can cause the teeth to break, and it can cause the artificial dentures to just fall out. Okay, and making it difficult to intubate it, even making it risky, because any broken denture can just go inside the windpipe, and it can further cause damage to the already compromised airway. Okay, so you got to make sure that you are asking all of these questions: past surgery, GA related complications, any post-op ICU admission, post-op nausea, vomiting, mouth opening, neck pain and neck stiffness, and artificial denture. Okay, all of it needs to be asked. All of it. You cannot just skip one or two particular things and then just get away with it. Okay, if you skip the ROS, if you skip a particular thing in the review of system, it's still acceptable, but making an error in this layer is not acceptable at all. Okay, so make sure that you do it. Then comes the P data, like about the diet, exercise, smoking and alcohol. You already know what the P data is. I'm not going to get into a lot of details of it again. Okay, now in this case, The meftosa becomes particularly important. Okay, and amongst the meftosa, the most important thing is the medicines that the patient is taking. I'll tell you why later on when I discuss the pre-operative pearls with you. Okay, if the patient is on blood thinner medication, you have to stop it before the surgery. Okay, if the patient is on antihypertensive, it needs to be stopped. If the patient is on steroid, the dose of the steroid needs to be double post-operatively. Insulin, if the patient is taking insulin, you got to stop that, and then you got to start the patient on a sliding scale. Okay, so there are different guidelines for all of these medication. Blood thinner needs to be stopped, antihypertensive needs to be modified, insulin needs to be modified, steroid doses needs to be changed. Okay, so you gotta be aware of the medicines or the drugs that the patient is currently on. Okay, ask them. Okay, ask direct question, by any chance are you on any blood thinner medications, any antihypertensive that you take. Okay, if the patient has given you some clue in the past medical history that yeah, that I'm doctor, I am diabetic, then your next question should be, okay, by any chance are you taking any antihypertensive, can you please tell me which antihypertensive medication are you taking. Okay, so medicines is like really really important. Okay, you gotta ask this. You cannot just ignore it, and you cannot just get away by not asking the medical the medicine history or the drug history. Okay, then the allergies you can talk about, family history fine, travel is also fine, not that relevant. But what is relevant? Occupation. Okay, in the psychosocial aspect. Okay, why is occupation important? Because some things, there are few occupation that needs to be stopped after the operation, after the surgery. Like for example, I've written it down. The mechanical work need to be avoided. Like in a lot of cases, specifically in the cases of herniottomy or hernioplasty, you gotta stop a construction worker from lifting heavy weights. Okay, a patient who has gone surgery, they cannot get into the mechanical work until their incision is healed completely. Okay, so you gotta ask about the occupation. But let's suppose if somebody says that doctor, I am a software developer, I just work from home. Fine, that they can continue their work from home while sitting on the bed, while being on bed rest. Okay, so the occupation is like really really important. Okay, then comes the social history. Okay, psychosocial, I've just divided into two parts because both of the aspects were like really really important. So I'll just share with you what kind of social history you need to take and why is it important. Okay, number one, who do you live with? Somebody is getting a surgery done. Okay, post operatively the patient may need assistance. Okay, the patient may need support with walking, patient may need support with cooking food and eating. Okay, so you got to make sure that okay, the patient is not living alone. If the patient is alone, you may have to arrange some caregiver, or you may just keep the patient in the hospital depending on the situation of the hospital. Okay, so that is why it's very important to ask that who do you live with or who are you currently living with. Okay, then how is the home infrastructure? Okay, why is this question important? I'll just share with you why is this question important. There are few cases like total knee replacement and total hip replacement in which you may have to do the discharge counseling. Okay, and question like these like would become particularly important because a patient with having total knee replacement or total hip replacement, they would have a difficult time in walking. So you gotta ask about the infrastructure, that okay, do you have an attached washroom in your home? Okay, do you have on which floor do you live? Like, is it on the ground floor, is it on the first floor? Okay, the floor on which you live, does it have a washroom available? Okay, is your house spacious enough? Okay, do you have enough walking space? Because people like this are going to need infrastructural assistance as well, because they may not be able to climb the stairs again and again. If their washroom is on the ground floor and they live on the first floor, it would be very difficult for them to come down 3 to 4 times a day with a hip, with a replaced hip, with a replaced knee. Okay, so you may have to arrange a bed on the ground floor. You may have to shift them to a nursing home which has a washroom facility much more readily available. Okay, then you got to ask that are you able to do your task on your own? Okay, because that would assess that okay, how much dependent that particular person is. If the person is already dependent on someone, and they're getting discharged, they would need greater amount of help and greater amount of assistance from someone. Okay, so you're going to suggest them that, okay, can you call someone from your family, can you call someone from your friends, to be there with you. If they cannot come, okay, no problem, you can stay in the hospital for a few days. Okay, if you cannot stay in a hospital for a very long time, there are care homes available, there are caregivers who can come to you and visit to you, there are some nurses who can come and visit you and give you your medications, and uh, get you to move, and get you move out of bed, make sure that you start mobilizing and all. Okay, so social, like the psychosocial aspect, the occupation, and the social history, like is like it's very very important in the surgical cases. So in the meftosa, we discussed two things so far: the medicines, okay, and the psychosocial aspect, the occupation, and the social history. All right, then the anything else, okay, very important, very important. And this question is something that a lot, like most of the candidates end up missing this question: that are you Jehovah's Witness? Okay, and we have seen cases like these in our Plat 1 exam. Okay, because these are the people who are against the idea of blood transfusion. They have reservations against blood transfusion. Okay, and why have I added this question in the structure is because the patient is going into a a surgery. Okay, you're going to order pre-operative investigations, and you're going to run the full blood count, and you're going to uh, offer the clotting profile as well. Okay, the patient may be at a risk of bleeding. Okay, so in the back of your mind you would be like, okay, yeah, fine, I'll just arrange 2 pint of PCVs, and I'm going to arrange some blood products during the surgery. But you did not ask about the fact that if the patient has any reservations against blood transfusion, because in that particular case you cannot transfuse the blood, even though if the life of the patient is at risk. All right, so you have to make sure that you ask this particular question, and you do address this question. Okay, and if they have any reservation against blood transfusion, there is a way to manage that. Okay, and I'll tell you later on when we go down in this lecture. All right, so yeah, this was the pre-operative assessment. Okay, and it is a completely different structure. It is very different from the others. Okay, and you need to make sure that you have the pre-op structure in your mind. Very rarely it may show up in the exam, but you don't want to take any risk. You want to make sure that you are very well prepared. So this is the structure for you. Okay, I hope I have explained it to you very clearly, and let's just move on to a few important things that you should be aware of when it comes to the surgical cases. Okay, all right. Now I've got some pre-op pearls and some post-op pearls as well. Okay, these are the things that you should remember, because it would be very beneficial for you when it comes to the management. Okay, the direct oral anticoagulants, they need to be stopped 2 days before the surgery. You need to remember that. If somebody says, when you ask them, are you on any blood thinner medication, and they take the name of the drugs, you're going to in the management you're going to stop these medications. Okay, if the patient is on aspirin, stop it 7 days before. Warfarin needs to be stopped 5 days before the surgery. Oral diabetic medication, okay, they just need to be stopped on the day of the surgery. All right, if the patient is on insulin, it needs to be stopped on the day, and it needs to be shifted to something called the sliding scale. Okay, ACE inhibitors stopped on the day of the surgery. If the patient has any migraine and is taking sumatriptan, it needs to be stopped 1 day before the surgery. Okay, then hemoglobin more than 10 is required for all the elective surgeries, and at least a hemoglobin of 8 is required for the emergency surgery. Okay, so if the hemoglobin is less than 10 and it's an elective surgery, it's a non-emergent surgery, you have to postpone the surgery until the blood is transfused, until the hemoglobin is corrected. And for the emergency surgery, it needs to be at least more than 8. If it's not more than 8, then you need to arrange some blood products and make sure that the blood products are there, considering that the patient is not has any reservations against blood transfusion. Okay, then another advice that you need to have in your mind is the NPO. You need to keep the patient nil per hour for 6 hours for food and minimum of 2 hours for water. Okay, in my home country we used to like we were very cruel. We used to keep the patient NPO for 10 to 12 hours. Okay, but the guidelines says that okay 6 hours is like more than enough, and it reduces the risk of aspiration if the patient is NPO for 6 hours. All right, just follow the guideline and just say 6 hours. All right, then the steroid dose needs to be doubled post-operatively. If the patient says that they are on steroid, then you got to say this thing in the management that okay, the dose needs to be doubled. All right. Then comes the post-operative pulse. Okay, very important. Uh, but before I move on to the post-operative pulse, let me just give you a brief overview of what to expect in the management of the pre-operative cases. Okay, so in the pre-operative cases, after you're done with the pre-op assessment, after you've done with the data gathering, okay, done with the examination and all, you're going to say that okay, from the chat we have had and from my examination findings, well, you seem fit for the surgery, and hopefully we will be able to get you on the list for the surgery. All right, and then you start the IRMAS protocol. Okay, the IRMS protocol would be again investigations. You name all the relevant pre-op investigations, baselines, blood clotting profiles. Okay, infectious markers, hepatitis B, hepatitis C, HIV. Okay, and all those tests that are important for the surgery: chest X-ray, ECG, echocardiogram. If somebody is age more than 40, okay, they need cardiac fitness. They need ECG and echo as well, just to make sure that cardiac fitness is there. All right, then after the I part you got to go to the R part, that is the referral part. Okay, so a referral may or may not be needed. All right, it really depends, and it varies from case to case. Sometimes post operative cases you may have to refer the patient to different specialities. Okay, I'll talk about it in a while. Then comes the medicine, the M part, or the medical management part. Okay, the medical management can be post-operative pain medications, post-operative antibiotics. Okay, and if it's a pre-operative case, then this is the medical management that I just talked about: stopping medications and modifying the doses and changing the regimen of a particular drug that they might be taking, making the patient optimized for the surgery, transfusing blood, keeping the patient NPO. Okay, all of these things come under the heading of the medical management. All right, then advices. Okay, you may have to give some advices to the patient that okay, try to get some support, try to call someone from your family. If you're living alone, try to call someone from your friend circle. And then if the patient is smoking, if the patient is taking chronic alcohol, then you have to you may have to give them some advices, that okay, you got to stop smoking, you got to stop alcohol before your surgery, because it may delay post-operative healing. It may result in unwanted complications during your surgery. uh, so you may have to provide some advices like, you may have to take some off from your work, you may have to take a leave, you may have to take you may have to delay your exams. Okay, so all of those things would would come under the advices. And then just brief safety netting, that if your symptoms worsen before the surgery, then you can go to the A&E and all. Okay, so this is what the IRMAS protocol is. All right, in the advanced protocol, I told you that the patient do ask some concerns. Okay, they often end up throwing some concern or the other. Okay, and the possible concerns that they're going to throw is something that I have mentioned here in the post-op trials. Okay, their concern would be that, doctor, when can I assume my normal activity? Okay, so like typically the surgeries which are invasive, okay, they take up to 2 to 3 weeks to like recover and make sure that the patient can continue their normal activity. So like after every surgery you would advise to the patient to take a rest of 2 weeks. All right, then the patient may just ask, okay, the doctor, when can I start having sex? Doctor, when can I drive again? Doctor, when can I resume my work? So the sex, drive, and resuming work can be done in 4 to 6 weeks. Okay, and this is for all surgeries and for MI as well. Okay, I've mentioned it because the patient of myocardial infarction, even though it's not a surgical case, but they often ask that, doctor, when can we begin having sex, when can we drive, when can we resume our work. So you can use this same piece of information for the MI patients as well. Okay, but since we are doing surgery right now, so just keep in mind that normal activities can be resumed in 2 to 3 weeks time, and the sex, driving, and work can be resumed in 4 to 6 weeks. This is for all the surgeries, but for total knee replacement and total hip replacement, the time duration kind of gets a bit increased. Okay, so instead of 2 to 3 weeks, the normal activities are resumed in 4 to 6 weeks. Okay, so this changes sex, work, and driving, like instead of 4 to 6 weeks, this is now 6 to 8 weeks. Okay, so you have to have this thing in mind, because TKR and THR, it, number one, it takes much more time in healing. Number two, the kind of joint that is involved, you cannot just begin your normal activity just like that. Okay, it needs more time to recover. It needs more time to like get sorted. Then patient may just throw some concern that, doctor, when can, since how long, like since how many days I will be in my pain, and like when will my pain go away. So the pain is remains there for 3 months. Okay, you need to like just say, okay, the pain is going to be there for 3 to 4 months. Then they're going to say that, doctor, since like how long will the swelling be there. So the swelling would be there for at least 12 months, or you can say at least a year. Okay, then they may throw some concerns that, doctor, like when can we fully recover from this. So full recovery may take up to 2 to 3 years as well. Okay, so you should be aware of these things. Okay, and in order to be confidently able to address the concerns of the patient. Okay, because these are the common concerns that they will like throw you after the if you're discharging someone post-operatively, and like all the post-operative patients, specifically in these cases. Let me just show it to you. Yeah, in the discharge counseling, like it's definitely these concerns are going to be there. Okay, so make sure that you are well aware of it. All right, and in few pre-operative cases as well. Okay, like the patient may say that, okay, doctor, after the operation and after the surgery, when can I recover. Okay, so these concerns may show up in the pre-operative consultation as well. So you should be aware of this particular knowledge in order to be confident in your consultation. All right, then there is a service that I would like to tell you about, and this is something that would be very helpful in the total knee replacement and the total hip replacement case. That is the mobility clinic. Often patient having joint condition, or having issues like arthritis, or having issues which causes issues in their mobility. It can be neurological conditions as well. Okay, but anything that is related to mobility issues, all of these patients are referred to the mobility clinic. They're not referred to orthopedics. They're not referred to like physiotherapists separately, but mobility clinic, because it's a one-stop solution. Like I talked about a few one-stop solutions in the obgyn and the antenatal structures as well. Okay, so this is one another uh, one-stop solution that would provide medical consultation, that would provide the orthopedic consultation. If a rheumatological condition is involved, so the rheumatology department representatives are going to see the patient. Neurological disorders will be seen by neuro. Then the other aids would be there, like physiotherapy would be there. Then the rehab would be there. The rehab programs and the rehab workshops would be there. They're also going to provide them with mobility aids like a walking stick or a walker. Okay, like whatever works for that particular patient. So all of it would be provided at the mobility clinic. Okay, so you need to make sure that you are aware of it and you're using this particular terminology in your consultation. Do not just be a mediocre and average candidate who haven't watched DSS videos and just end up saying orthopedic and physiotherapist, and I'm going to send you to a shop where you can go and buy the walking aids and all. Be smart. Okay, and just use this knowledge to you know say that I'm going to refer you to the mobility clinic. Okay, and this is the referral that I talked about, that in the IRMAS you may have to refer the patient somewhere or the other, and this is the referral. Okay, now what to do with the Jehovah's Witness, and what to do when a person is refusing blood transfusion. Okay, so what you have to do is that, number one, you need to tell them in the management part. Okay, and this is something that you would, uh, like tackle in the medical management part, and or the advices part as well. You can do this. It depends wherever you want to place this thing, but it needs to be done in those patients who are reluctant to get like the blood transfused. Okay, so in the management, you got to ask about the evidence that they would have to provide an evidence that they are the Jehovah's Witness and they refuse blood transfusion. Okay, number one. Number two, they may have to sign a written declaration. Okay, so how you're going to word it, I'll tell you in a while, and you would have to involve your seniors. Okay, these are the three things that needs to be done. Okay, so if someone comes to you and they said that, okay, no, doctor, we are Jehovah's Witness and we, I do not want any blood to be transfused. So what you are going to do, that instead of just throwing these three pointers at their face, tuck tuck tuck, that no, I'm going to involve my seniors, write a declaration, provide me evidence. So just be respectful of their decision. That okay, thank you so much for giving me this piece of information, Miss Anna, and we respect your decision of not getting the blood transfused. But just let me tell you that the kind of surgery that is planned in your case may have a risk of bleeding. Okay, and if you start bleeding, your blood pressure will start to drop. Okay, and we will not be able to do a life saving maneuver that we do in form of a blood transfusion in your case. But we're not going to just leave you like that. What we're going to do is that we're going to try our best in situation like this, that we try to maintain your blood pressure and we try to give you as many fluids as possible. But let me tell you that giving fluids would not be that effective as compared to giving the blood. However, we respect your decision, and since you are one of the Jehovah's Witness, number one, what I'm going to do for you is that I'm going to involve my seniors, so that they're going to come and have a chat with you just for your further confirmation. Other than that, we would need to see an evidence of you or your relative being a Jehovah's Witness, and you may have to sign a written declaration that you or your relative want to refuse the idea of blood transfusion in case of a emergency. Very simple. Okay, that's how you're going to explain it. So do not be very judgmental, and always be respectful of their choices. Okay, so that's how you're going to tackle this, and you're going to see this particular scenario in this particular case, in this one. Explanation counseling, the laparoscopic um, cholecystectomy case. This is where you're going to probably get the concern of the patient refusing blood transfusion. But let's not be scripted. Okay, let's not just get this thing in mind. Okay, that it will only come in this particular case. It can come in any case. But I've taught you the basics. Okay, so you know that you have to ask it, number one. And if somebody turns out to be reluctant for blood transfusion, how to manage that. We've also discussed this particular thing. All right. Another important thing, the TKR and the THR case. Okay, we often have to, refer these patients. Okay, to different kind of therapists. Okay, so there is a very common confusion amongst the IMGs for some reason between what is a physiotherapist and who is a occupational therapist. Okay, so a physiotherapist is basically, like most of us know what a physiotherapist is. They basically just specialize in movements and making sure that they're able to get the strength of that particular organ. If there is cardiac therapy, if it's a orthopedic therapy. Okay, depending on case to case, they just try to bring back the normal strength, bring back the normal function, and bring back the movement. Okay, uh, that is what they work on. Okay, the medical aspect of the mobility and the medical aspect of the strength and medical aspect of reducing the pain, and making sure that your body gets back to normal, your body's normal physiology is back again. Okay, that is what the physiotherapist is. The occupational therapist has nothing to do with the medical aspect of it. Has nothing to do with the clinical aspect of it. What the occupational therapist does is basically they try to assist you, when they try to help you in a lot of different things that will help you perform those daily activities, and that will help you achieve your normal body physiology much faster. Like for example, they may just provide you with strategies. Okay, like for example, the physiotherapist is going to come and he's going to say that okay, you need to walk, and you need to make sure that you ensure your mobility. The occupational therapist, what they are going to do is that they may provide you with like the stairs that are there, the dummy stairs. Okay, they would provide you with that particular equipment, and they'll say that okay, fine, you live on the ground floor, you do not have access to the stairs, we're going to provide you with just the dummy stairs on which you can just take some steps. Okay, this is how the occupational therapist is going to help you. They would, they may get involved in your occupation as well. They may give you occupational advices, like for example, okay, fine, you had a surgery, you had a hernia repaired, uh, so we would like to tell you that you cannot lift heavy weights. Okay, so the occupational therapist is going to be there with you and help you in your adjustment that you need to do in your work. That maybe that they may just change your work nature from mechanical to an administrative work, or a managerial work for some time. Okay, so these are the things that the occupational therapist would perform, and these are the things that the occupational therapist would you know assist you in. So they provide a much more holistic approach to your recovery. Okay, so do not get confused and get the idea what occupational therapist does. All right, if let's suppose that if somebody lives on the first on the ground floor. Okay, and they have a washroom that is just present on the first floor, what they may do is that they may just install a temporary escalator that is attached to the stairs, just to help them move up and down and use the services that are there on the first floor. Okay, all of these things. Okay, these are the services that are provided by the NHS through the occupational therapist. Okay, so do understand the role of the occupational therapist and the difference between the physiotherapist and an occupational therapist, because I don't really want you guys to end up getting confused and end up using the terminology of occupational therapist in the wrong sense. Okay, so yeah, this completes the basics and this completes the structure of the preoperative assessment, particularly, and the surgical cases. But as I mentioned, that there are so many different cases. Okay, and you would not be able to get the idea of it until you go and read the notes and you read the management pointers of all of these cases that are mentioned here on the screen. Okay, go and read the notes. I know I do understand that the notes, and I'm not a very big fan of the notes that are there in the market. But since you have this structure over here, what you can do is that you can pick up this structure and pick up the notes and try to incorporate that knowledge as per this structure. Okay, as per the IRMAS protocol, as per the weight protocol, and then make sure that you practice your cases accordingly. And if you were to ask my recommendation, I do not particularly recommend like a lot of note sources that are there. I'm not going to name any of them, but computerized Novanika is a note source that is like really accurate. That is the most accurate, and that is the most well drafted note source that you'll ever find. Okay, all the other note sources, unfortunately, no offense to any academy, no offense to any particular tutor, but like there are a lot of flaws in it, and they either just make you focus on just a few cases that are taught in their lectures, in their crash courses, and they just give you that impression that these are the only cases that you should be doing, and you'll be good to go in the exam. But that's not actually the case. There are 600 cases in PLAB 2, and trust me on this, you need to do all of them in order to succeed. You need to do all of them. You need to at least go through all of them at least once or twice. Okay, if you're not doing that, if you're just relying on 200 to 50 cases taught by a particular tutor in their crash courses, then like you may just master those 200 to 50 cases. But what if 2 to 3 cases comes out of the syllabus, out of those 250 cases that you have studied? You're going to panic and you're going to be, taken by a surprise in the exam, and then that is going to have a very negative impact, and you may just end up, not clearing your exam. So do not just rely on those notes. Do not just rely on the notes that are present in the market, thick volumes, like 10 pages for one particular case, and like big scripts. Okay, don't follow them as well. I'm not a very big fan of them. I don't recommend them. But nevertheless, you have to follow some note source, and that is why I recommend computerized Novanika. It's the most balanced note source that you're ever gonna find. And the cases which are not there in computerized Novanika, those cases you can search in the other note sources that are available in the market. Okay, so with that, I'll end up the surgical consultation or the pre-operative assessment structure and approach. I hope that I have clearly taught it, and it's clear in your heads and it's clear in your minds. But if it's still not clear, then drop your queries in the comment box. Reach out to us on our social media, and if you want to have a personalized mock with us, then scan the QR code and sign up for a mock, and my team is going to schedule one mock for you with me. Okay, so with that, I'll take your leave and see you in the next lecture.